A 47-year-old woman undergoing investigations for secondary amenorrhea and joint pains. So here we are talking about secondary amenorrhea. So earlier we spoke about a primary amenorrhea. Now here it is secondary amenorrhea. There is also some joint pains. Blood tests show FSH level to be 40. Reference value is 30. So this patient is postmenopausal. So the reason for this secondary amenorrhea is that she has attained menopause. So this postmenopausal woman who is a non-smoker with a BMI which is normal and with an intermediate risk on a FRAX score. FRAX score is something that we do to assess a 10-year fracture risk. Subsequently has a DEXA scan performed with a T-score of 0.8. Now T-score, what is the T-score? You compare the bone mineral density of your patient to the bone mineral density of a young adult to see whether there is any decrease in the bone mineral density. So what happens? T-score, what is a normal T-score? -1 to +1 is a normal T-score. So our patient's T-score is in the normal range. So in this patient, we will just advise healthy lifestyle, nothing beyond that. If the T-score is between -1 to -2.5, we call this osteopenia. So here we address lifestyle related factors, address vitamin D levels, look for vitamin D deficiency, correct it if it is there, and put the patient on vitamin D and calcium supplements. If it is less than -2.5, if T-score is less than -2.5, then this is osteoporosis, which is where all these agents will have a role. So here we are dealing with a normal individual. Now, a 56-year-old woman is commenced on carbamazepine, which is an anti-epileptic medication for suspected complex seizures. She is not on any other medicines. Within 10 days, the patient complains of feeling dizzy and unsteady. She is brought to the hospital by her husband with severe confusion and vomiting. Clinically, she is euvolemic. Her investigations show a sodium of 124, potassium is 3.7, creatinine is normal. Her urine spot sodium, the cutoff is 20. 20 to 40 is equivocal, more than 40 is increased. So, urine spot sodium is increased and urine osmolarity is also increased. Which of the following is the most likely cause for hyponatremia? To solve this question, we need to know an approach to hyponatremia. So, what do you do whenever you have a low sodium? The first thing to do is to look at the osmolarity, the serum osmolarity. So, when you look at the serum osmolarity, only if the serum osmolarity is also low, you conclude that this is a true hyponatremia or a hypotonic hyponatremia. If the serum osmolarity is normal or high, then it will be called pseudo hyponatremia. Pseudo hyponatremia can be caused by hyperglycemia, by hyperlipidemia, by paraproteinemia, all of these conditions, and also in patients on osmotic diuretic. Now, this patient with a low sodium, they have not mentioned the serum osmolarity anywhere, but let us assume this is a true hyponatremia because even here they have not mentioned any causes of a pseudo hyponatremia. Now, in this patient, the next thing to do once you have confirmed that the serum osmolarity is also normal is to basically look at the urine spot sodium to see if there is any urinary wasting of sodium. The next thing to do is usually a urine osmolarity. So, once you do a serum osmolarity, you do a urine osmolarity. When you do a urine osmolarity and you find that the urine osmolarity is very low, then you are dealing with primary polydipsia. That means the patient just keeps drinking a lot of fluids and that is the reason behind the low sodium. This is almost pushing the patient to develop a dilutional hyponatremia because the patient is drinking a lot of fluids. The urine osmolarity, the patient passes a large volume of dilute urine, therefore the urine osmolarity is going to be low. Now, once your urine osmolarity is increased, then you will have to see whether there is any urine sodium wasting. So, you do a urine spot sodium. If the urine spot sodium is actually low, if it is less than 20, then it could be that the effective circulatory volume itself is reduced. For instance, we could be dealing with hypovolemic causes which decrease the effective circulatory volume like diarrhea, vomiting. In all of these, the urine spot sodium is going to be low. Or you could be dealing with conditions, hypervolemic conditions, which are going to decrease the effective circulatory volume like cardiac failure, hepatic failure, or nephrotic syndrome. So if your urine spot sodium is high, that means you could be looking at one of these. Either you could be dealing with diuretic use. So once you rule out diuretic, you look at the volume status of the patient. There are 3 important causes of euvolemic hyponatremia, because here they mention clearly that the patient is euvolemic. These are the 3 causes that you should look for: hypothyroidism, hypocortisolism or Addison's, and then you have syndrome of inappropriate secretion of antidiuretic hormone, SIADH. Now here they have clearly mentioned that the urine sodium is low. Then you travel here, the urine spot sodium is high. So you're looking at one of these causes. She is not on, they've clearly mentioned she is not taking any other medicine. So diuretic is ruled out. So one of these 3. Here they have not mentioned that she is on any iatrogenic steroids. There is no mention of any condition like asthma which may require her to be on long-term steroids. They have not mentioned any measurement of 8 AM or a 4 PM serum cortisol. They have not mentioned any measurement of TSH. So these 2 we will put aside. The only other relevant history here is going to be carbamazepine use. We know carbamazepine, a lot of important causes for SADH. Broadly we can divide them into drugs, infection and malignancy. Lot of Parkinsonism and anti-epileptic agents and antipsychotic drugs can result in SADH. So whenever you have these agents and this picture of a euvolemic hyponatremia with sodium wasting, you're going to first think of SADH. So here in this patient, is it Addison's? Low sodium, yes, could be Addison's. As I mentioned earlier, Addison's can also cause euvolemic hyponatremia. But what goes against Addison's in this patient? The fact that the potassium is actually normal. Addison's disease is usually associated with hyperkalemia. That is not there, so we are not dealing with Addison's. There is no history of vomiting here, and more importantly, as I said, vomiting causes hypovolemia. That is going to effectively reduce the effective circulatory volume. Therefore, in a patient with vomiting, you do a urine spot sodium. How is it going to be? It is going to be reduced. It is usually less than 20. That is not the case here. So, vomiting is ruled out. Is it seizures? Can seizures just like that cause hyponatremia? It is not a well recognized cause for hyponatremia per se. So, this is not relevant. So, you are between cerebral salt wasting and SADH. Remember, cerebral salt wasting and SADH can both have very similar biochemical profile. In both, the sodium is going to be low, the serum osmolarity is going to be low, the urine osmolarity is going to be high, and the urine spot sodium is going to be high. Now, how will we differentiate between the 2? Usually, cerebral salt wasting, these patients have some kind of a CNS insult. That is not seen here. Usually they have a multi-infarct state. That is not evident here. There is no mention of a CT, no recent brain injury or a CNS insult. That is not there. So, unlikely. Here instead you have carbamazepine, and we know it is closely associated with SADH. So that crucial aspect in the history makes a choice of SADH more likely than cerebral salt wasting. But remember, cerebral salt wasting, because these patients will be passing large volumes of urine, you will find that when you put these patients on fluid restriction, in SADH the urinary volume will significantly come down, the sodium will start improving. But in cerebral salt wasting, even with fluid restriction, the sodium is going to be low because these patients are going to pass large amounts of urine. So therefore, usually these patients are hypovolemic. The fact that here they mentioned that she is euvolemic again goes slightly against cerebral salt wasting. So the answer is SADH. Now next question, we have an 18-year-old man with meningococcal sepsis. This patient was treated with ceftriaxone, develops gangrene requiring amputation. Now post-operatively he complains of flank pain, becomes drowsy, lethargic, hypotension, cool peripheries. So this patient is developing a hypovolemic shock. If it is a septic shock, usually you will have warm peripheries, bounding pulses. That's not there. Now plasma creatinine is normal, urea is 9.6, but potassium is high and sodium is low. Remember what we were speaking about the sodium and potassium when we were speaking about additions earlier. So, sodium being low and potassium being high, this kind of an abnormality should instantly point towards an adrenal insufficiency. So, here you are able to see that in adrenal insufficiency, usually patients have metabolic acidosis. So, in keeping with that, the bicarbonate is going to be low. Urine spot sodium is 30 milliequivalent per liter. So, that is equivocal, and which of the following is the most likely cause for this deterioration? Once you pick up the potassium being high despite a normal creatinine with a low sodium. So, low sodium, high potassium, normal creat. This tells us that the culprit must be the adrenals. So, there is adrenal insufficiency. In a patient with meningococcal sepsis, they typically described a stormy event, sudden onset of shock with flank pain. So, this is typically seen in Waterhouse-Friderichsen syndrome, where the patient develops adrenal hemorrhage. So, here the most likely cause for his deterioration is adrenal insufficiency. Now, a 25-year-old woman goes to a GP complaining of tiredness and thirst. She tells you that she has no significant history of previous medical problems apart from 2 episodes of kidney stones. In terms of family history, her father had 2 of his parathyroid glands removed because of high calcium and recurrent pancreatitis when he was in his 30s, but this didn't seem to cure the problem. On examination, she looks well, blood pressure is okay, BMI is okay, pulse is okay. So, from this slide, there are a couple of things we picked up. One, this particular patient has had some kidney stone, tiredness and thirst. So, always remember, whenever this tiredness and thirst is there, either you could be looking at a DI or it is hypercalcemia. So, here because of the kidney stone, we are going to think more in terms of hypercalcemia, and to support that there is a strong family history. What family history is there? There is a history of a parathyroid and a pancreas involvement in the father. So, but this didn't seem to solve the problem. Where do you find parathyroid and pancreas involvement? Pituitary, parathyroid and pancreas. This is the triad for MEN1 syndrome. The most common here is the parathyroid, that is going to be followed by a gastrinoma in the pancreas and a prolactinoma in the pituitary, that is more commonly. But basically a parathyroid tumor, parathyroid adenoma or hyperplasia causing hyperparathyroidism, and a pancreatic tumor and a pituitary tumor is the triad that makes up MEN1. Now here what do the investigations show? We are able to see that the counts are normal, the electrolytes seem to be normal, creatinine is normal, calcium is markedly high. When the calcium is high, if it is not driven by the parathyroid hormone, you expect it to be suppressed. That is not happening here. Now, parath hormone is also high. So, this tells you that this patient probably must be having primary hyperparathyroidism. Now, what is the most likely diagnosis? As I mentioned, you have a high calcium and you have a high PTH, there is previous history of stone disease in this patient, and there is family history suggestive of hyperparathyroidism. So, this points towards primary hyperparathyroidism. If it was a pancreatic tumor in the father, then we are probably looking at MEN1. So, here remember we are talking about primary hyperparathyroidism. Can it be any of these? As I mentioned, in secondary hyperparathyroidism, your calcium is going to be normal or low normal. So, no. In hypoparathyroidism, both PTH and calcium will be low. So, that's not seen here. So, no. FHH, familial hypocalciuric hypercalcemia. This is a very unique entity which is going to cause elevation in PTH, elevation in calcium level, but the only way to differentiate between primary hyperparathyroidism and FHH is in doing something called a urine calcium creat ratio. When you do a urine calcium creat ratio, if it is high, that points towards primary hyperparathyroidism, and if it is going to be low, that points towards FHH. But here, because of the history of renal stones, which probably points towards a hypercalciuria rather than a hypocalciuria, we don't think this is FHH. And in osteomalacia, vitamin D deficiency in adults causes defect in the mineralization with decrease in calcium and decrease in phosphorus, and that is called osteomalacia. That is again evidently not the case here. So, primary hyperparathyroidism it is. A 35-year-old man comes to the clinic complaining of tiredness, lethargy and an increasingly hoarse voice. So, this tiredness, lethargy and hoarse voice, you are already thinking of hypothyroidism. Some loss of hair, fullness in the neck, probably a goiter, weight gain, puffy face, periorbital edema, painless goiter, pulse is low, blood pressure slightly on the higher side. Medical history includes celiac disease, and he tells you that the mother has a history of an underactive thyroid gland. So, from all of this, we've already drawn a few conclusions. One, this patient has hypothyroid features. Two, because of celiac disease and the mother having some thyroid problem, you are thinking more in terms of an autoimmune thyroid disease causing this hypothyroid problem. So, you look at the counts here, counts are normal, electrolytes and renal parameters normal, TSH is high. This is consistent with the diagnosis of primary hypothyroidism, which is consistent with all our clinical features suggestive of hypothyroidism. You look at the cholesterol, cholesterol is high, again probably secondary to primary hypothyroidism. Triglycerides are high, secondary to primary hypothyroidism. LDL is high, so this pattern is secondary to primary hypothyroidism. Fine needle aspiration reveals diffuse lymphocytic and plasma cell infiltration. All of these go in favor of Hashimoto's thyroiditis. So, this is what we are dealing with. In patients with TSH deficiency, TSH level will be low, that is not seen here. De Quervain's thyroiditis is basically a subacute granulomatous thyroiditis where patients may have features of hyper or hypothyroidism, or they may even be euthyroid, but they generally have elevated inflammatory markers. They may even have pain. So, all that is not there here. So, unlikely you are dealing with De Quervain's. In Graves' disease, the parameters will be exactly opposite. TSH will be suppressed. That is not the case here. Thyroid lymphoma, the features here do not fit in with thyroid lymphoma. It just shows a rubbery painless goiter. That's all it is. So, here the and biopsy has only revealed lymphocytic and plasma cell infiltration. No lymphoma cells seen. Therefore, you are dealing with Hashimoto's thyroiditis. A 27-year-old woman presenting with polyuria is found to have diabetes insipidus. So, remember what I told you, whenever you have this polyuria, increased thirst, not two conditions. One, diabetes insipidus. Two is going to be hypercalcemia. Now, this has resulted after a head injury from a motorcycle accident. Which part of nephron is most affected in this condition? So, they've asked the question in a very strange manner, because the moment we start a question about diabetes insipidus, head injury, you're thinking, okay, this patient has a cranial diabetes insipidus. But they threw you off guard by asking you which is the portion in the kidney which is responsible for diabetes insipidus. So, remember, diabetes insipidus is the opposite of SADH. In SADH, there is excessive antidiuretic hormone or vasopressin. Now, this vasopressin is deficient in patients with diabetes insipidus. Now, in patients with cranial diabetes insipidus or central diabetes insipidus, what happens here? You find that the levels of ADH are low. Usually, these patients have some pituitary damage which results in decrease in vasopressin levels, which results in central diabetes insipidus. Now, nephrogenic diabetes insipidus, what happens? Usually seen in the context of patients who have been taking drugs like lithium. What happens? This vasopressin, it basically acts at the level of collecting ducts in the nephron. So, that portion is going to be involved. The vasopressin receptors are going to be damaged. So, although ADH levels are normal, ADH action is impaired because of resistance at the level of the receptor. Therefore, which is the nephron that we are talking about in diabetes insipidus? We are talking about the collecting ducts, the cortical and the medullary collecting ducts. So, this is what it is. Now, we have a 26-year-old woman who presents with increased hair growth on her arms, legs and body. She describes a So there is increased body hair growth. She describes a 6-month history of weight gain, particularly in the abdominal region. Noted purple striae. Menstrual pattern is normal. No family history of type 2 diabetes. Nobody has suffered from hirsutism. So this patient has hirsutism. This patient has a recent weight gain, predominantly central development of central obesity. There is this purple striae. So certain things really stand out. The moment you read purple striae, automatically the mind should go to Cushing's. So when you read there is no evidence of acanthosis nigricans, BMI is on the higher side, this patient is overweight, there is evidence of coarse black hair growth on arms, leg, chin and upper lip, so evidence of hirsutism is there. Pigmented purple striae are present. There is no evidence of virilization. So all these clinical features we have confirmed on examination. Hirsutism, weight gain, central obesity, purple striae. Which investigation is likely to establish the diagnosis? So this is a double jump question. First jump is in arriving at the diagnosis. So we have enough evidence from our history to tell us that this patient has Cushing syndrome. Recent weight gain, central obesity, purple striae, we are talking about Cushing syndrome. Which is the screening test for Cushing syndrome? It is 24-hour urine-free cortisol. So this is going to be the right answer. Remember, there are 3 important screening tests for Cushing syndrome. One is the 24-hour urine-free cortisol. The second is a midnight cortisol, a midnight salivary, or if salivary is difficult, a serum cortisol. What is the third test? The test which is widely used because it is very convenient. This is the overnight dexamethasone suppression test. So these are the 3 screening tests for Cushing syndrome. So of the options that are given here, only this is relevant to Cushing syndrome. Now you may ask me that this is only a screening test, but here in the question they mentioned most likely to establish the diagnosis. Therefore, you may get the feeling that they want a confirmatory test. Remember, in Cushing's, you confirm the diagnosis with a test called Liddell's test. What is Liddell's test? Liddell's test is a low-dose dexamethasone suppression test. This is the confirmatory test. These 3 are the screening tests. Serum adrenal androgen level is not something that we would do in patients with Cushing syndrome. That is something that we would do in patients with either congenital adrenal hyperplasia or in patients with adrenocortical carcinoma. Serum estrogen level is not relevant to Cushing syndrome. Karyotype is not something that we would do for this patient here. Serum prolactin level again is something that is not going to be helpful. So when would you do a serum prolactin level? Only when you are suspecting hyperprolactinemia or a prolactinoma. That is characterized by a triad of galactoria, amenorrhea and decreased libido. Whenever you have this combination, galactoria, amenorrhea and decreased libido, decreased fertility, this picture points towards hyperprolactinemia. So that is again not the picture here. So here you are looking at 24-hour urine-free cortisol. Now next question, we have a 21-year-old university student who presents for review. She is distressed by the fact that she is overweight, she has acne. So there is loss of scalp hair, troublesome facial hair, very similar to the previous case that we were discussing. BMI is on the higher side, age is only 16, has irregular menses, mother has type 2 diabetes, which fits into this case. Although a lot of features are very similar to the Cushing's patient that we saw earlier, there are no specific features like a bull's neck, like a bull's hump. Although a lot of features are going to be similar between the case that we discussed previously, the Cushing's case, and this case here, there are no specific features like central obesity, purple striae, proximal myopathy, buffalo hump. All these are not evident in this case. So, Cushing's may not be a good idea to jump to Cushing's in this patient. All it mentions is that 1, there is an increase in the weight. 2, there is acne, some amount of facial hair, so probably hirsutism. So obesity, acne, hirsutism, irregular menses, common things are more common. This picture, whenever you see, particularly given that the mother has history of type 2 diabetes mellitus, you will be thinking of polycystic ovarian syndrome. So remember this picture where you have oligomenorrhea or amenorrhea and patients having features of hyperandrogenism in the form of hirsutism. So some menstrual abnormalities, evidence of anovulation or hypoovulation and hyperandrogenism in the form of hirsutism. These are the three things which will generally point towards a diagnosis of polycystic ovarian syndrome. So here, the fact that this patient has irregular menstrual cycles, some hirsutism, overweight, all this makes diagnosis of PCOS more likely than Cushing's. So in PCOS, what usually happens, you have an elevated LH-FSH ratio. This is because generally what happens in PCOS, the gonadotropin pulses are going to be abnormal in the sense that they are going to preferentially promote secretion of LH more than FSH, and this is what is going to give rise to the problem. So you are looking for an option which is going to give high LH and a normal FSH or a low FSH. So here you have a high LH, high FSH, this is ruled out. A normal LH, normal FSH is ruled out. Low LH ruled out. High LH, low FSH. So this picture here versus this picture here, both have high LH. The FSH is usually low or normal, so both could be right. You move further, you find that in PCOS is associated with hyperandrogenism. So there is going to be high testosterone. Sex hormone binding globulin is usually reduced in PCOS. So it is not associated with the high SHBG. That makes a diagnosis of that makes the last option the right option. So PCOS patients have a high LH, a normal FSH, normal estradiol and a high level of testosterone. So remember, whenever you have this picture, weight gain, some features of insulin resistance, features of oligo-ovulatory or anovulatory cycles, oligomenorrhea or amenorrhea, and hyperandrogenism in the form of hirsutism, you will think of PCOS. Now then we have a 45-year-old man who presents with episodes of tremor, sweating, incoordination, particularly when he wakes first thing in the morning. So on waking up in the morning, the patient is having some tremor and sweating. So here the first thing I am going to think of is a hypoglycemia. So because after an overnight fast, you wake up with this tremulousness, palpitation, sweating, tremor, that's what you think of, because every time in the morning, if these episodes are happening, then hypoglycemia is what I would think. But there is also an increase in the weight. This patient has some features of hypoglycemia, has weight gain. Examination is normal, BP is okay, pulse is okay, regular, BMI is normal, which is the most useful investigation to establish the diagnosis of insulinoma. So they've given us the diagnosis, and hence they've made our attempt in coming to a diagnosis with all of this unnecessary. So hypoglycemia, weight gain, you will think of insulinoma. So which is the hormone associated with reduction in blood sugar? It is insulin. Insulin is an anabolic hormone. So more insulin, more the weight, and more insulin, lower the blood sugar. In insulinoma, patients typically present with fasting hypoglycemia, because even during fasting what happens? Insulin level should be low, but because that does not happen, these patients typically present with fasting hypoglycemia. So here, what do you do to establish a diagnosis of insulinoma? Remember, in any case of hypoglycemia, it is very, very important to determine whether there is an endogenous insulin secretion. For that, when you take a fasting blood glucose sample at the time of hypoglycemia, in the same sample, you will measure an insulin and a C-peptide assay. It is very important to measure both insulin and C-peptide, because sometimes the insulin may be high, but the C-peptide will be normal or suppressed. Now that points towards factitious insulin use. All these points are important because the same question may be twisted in a different manner. So remember, whenever you have a case of hypoglycemia, there are a lot of things that you will have to rule out. You will have to rule out adrenal insufficiency, you will have to rule out hypothyroidism, have to make sure that the liver is normal, make sure the patient is not on any hypoglycemic drugs, and finally down the line, when you come to a conclusion of whether there is hyperinsulinemia, you will do an insulin assay along with the blood glucose. When the blood glucose is low, you expect the insulin to be suppressed. When that is not there, when the blood glucose is low and the insulin is high, that points towards hyperinsulinism. Now, how do you know whether this is exogenous or endogenous? That is where your C-peptide comes in handy. When your C-peptide is also elevated, that points towards endogenous hyperinsulinism. So, it is coming from the pancreas. Therefore, either the patient has insulinoma, or you do a urine sulfonylurea screen. The patient may have surreptitiously be taking sulfonylureas, causing a factitious hypoglycemia. Now what happens if the insulin is high but the C-peptide is low? That means this is again a factitious hypoglycemia caused by the patient taking insulin injections. So this is very important. In this patient, you will do a simultaneous measurement of fasting blood glucose and serum insulin and C-peptide. Insulin hypoglycemia test we just discussed earlier. Insulin stress test is something that you do to establish growth hormone deficiency. So that is not relevant here. Oral glucose tolerance test is something that you do to establish growth hormone excess in acromegaly. So again this is not relevant here. Measurement of HbA1c is done to diagnose diabetes mellitus. Not relevant here. Measurement of serum 3-hydroxybutyrate is not relevant. We check for ketone bodies in patients with diabetic ketoacidosis. This is the principal ketone body in diabetic ketoacidosis, although routinely we check for urine and plasma acetone. No, so this is again not the option here. Which is the right option? It is the last option.